Hello, everyone. My name is Susan Fishbein. I'm the facilitator of the Myositis Support Group. I'd like to welcome everyone and thank you for joining us as we continue in our celebration of Myositis Awareness Month. We are here to honor people who are living with myositis, their families, and their loved ones. To begin our Myositis Awareness Month celebration, in May, we had a session titled A Day in My Life, in which group members discussed the daily routines and challenges of living with myositis. Today, we're honored to have the second part of that celebration. We are also celebrating the 28th anniversary of the HSS Myositis Support Group, and I have had the honor and privilege to be facilitating this group for the past 17 years. We are dedicated to offering support and education for people with myositis and their loved ones, and to provide a sense of community for people with this rare illness. Even during the pandemic, we were able to come together and stay connected through our monthly support meetings on Zoom. Since that time, our meetings have pivoted to Zoom, and we've had even more people attending our group. We began with only 6 members in 1997. I'm proud to say that now we have reached 200 people who have become members of the Myositis Support Group at HSS, and thereby can reap the benefits of being part of a community. In addition to offering support and education for people with myositis and their loved ones, we are committed to raising awareness for myositis. We want to see a time when myositis is considered more often in making a diagnosis so that treatment can begin sooner. And one way that we do this is by presenting monthly programs such as this, and with expert speakers. Several of our programs are now available on the HSS YouTube channel, as this program will also be. This becomes a valuable resource, especially for people seeking help with myositis and for those who have limited access to care and treatment. For today's program, we're excited to have Dr. David Fernandez, our group's esteemed medical advisor and physician to many people with myositis here at HSS. He will present on the ever-increasing body of research being conducted for the treatment of myositis. Dr. Fernandez is an assistant professor of rheumatology at Hospital for Special Surgery in New York City, with a focus on the care of myositis patients, as well as translational research centered on inclusion body myositis. He completed his MD, PhD training at SUNY Upstate Medical University in Syracuse, New York. Before coming to New York City for internal medicine residency at Weill Cornell Medicine and rheumatology fellowship at Hospital for Special Surgery. His current research with colleagues at HSS is focused on single-cell RNA sequencing of CD8 positive T cells from blood and muscle of inclusion body myositis patients. He has been a site investigator for several myositis clinical trials at HSS, some of which are currently ongoing, and is interested in collaborating in clinical and translational research efforts. Dr. Fernandez will speak for approximately 1 hour. Questions may be entered through the Q&A or the chat box and will be addressed at the end of the presentation, at which time the recording will be stopped. Please be mindful that Dr. Fernandez will not be able to answer specific questions about your individual care and treatment. As always, this is best addressed during visits with your own physician. Your thoughts and opinions matter to us. Please take time to answer a brief anonymous survey provided in the link that I will provide in the link in the chat box. This also helps to give us information about how to develop programs that address needs and issues that are most relevant to you, and also gives our speakers feedback about their programs. Words cannot truly express the gratitude and thanks we feel to Dr. Fernandez. His dedication, his caring, his compassion, and vast knowledge have helped so many people with myositis. Many thanks to you, our members and friends and family, for joining us today. I'd also like to thank Mr. Demisvar Destin, who was working behind the scenes to make this recording possible. Our meeting will end promptly after the question and answer session. And again, I thank you all for joining us here. Without further delay, I'd like to present our guest speaker, Dr. David Fernandez.
All right. Well, thanks so much, Susan, and thanks to everyone attending. I'm terribly sorry that I wasn't able to make it last month, and I appreciate your flexibility and willingness to postpone. Yeah, so why don't I jump right in? So here, let me set this up. All right, how does that look for everybody? Is that okay? Okay. So so I give a version of this talk every year, and focusing on updates in myositis research. So there are some things that that I touch upon annually, and there are some things that hopefully are novel, and just things that I thought were interesting and relevant for patients that bore some emphasizing. So I'll begin just by touching on the broad topic of myositis research, and then turning to some kind of interesting reports about the epidemiology or causes of myositis, touching on exercise in myositis, and then turning to treatment, looking at a couple of different facets of that, including autoantibodies in myositis, as well as targeting a specific cell, white blood cell, called the B cell in myositis, and some novel directions in that regard. And then if I have time, I'll touch very briefly on some of the work we're doing at HSS, and then get to your questions. So yeah, so I think it's always hopeful just to get a sense of the community, that this is a large community that is growing over time with a lot of publications. And so there's nearly 30,000 results, and there were 1,300 papers published in the last year focusing on myositis. And so this is representative of the progress that's ongoing in this space. And it really feels like things are starting to move more rapidly and more like some of the other disease areas in rheumatology. All right. So then there were a couple of interesting papers having to do with epidemiology or potential causes or risk factors for myositis. And this is something that comes up very commonly, where most of the time we don't know the precise causes of myositis. So we have some idea, there's some event that sets things off, where there appears to be a connection temporally. But in many cases, it's not entirely clear why it happened. And we have only indirect evidence for that. And so this is one attempt to try to look at environmental or occupational exposures that might have contributed to myositis risk. And so this was from the NIH, and it looked at a large number of myositis patients who had completed a formal, structured environmental exposure questionnaire that quantified exposure to a variety of different exposures that are associated with other illnesses. So things like silica dust, solvents, dyes, heavy metals, things like that. And so there were lots of patients with dermatomyositis, polymyositis, and inclusion body myositis, and a subset of those also had interstitial lung disease. These were all patients who were seen at the NIH and whose diagnosis was, confirmed. They were, evaluated clinically by the staff there. And interestingly, there were some exposures that appeared to be linked or associated with a higher odds of having dermatomyositis or having lung disease. So specifically, the silica dust exposure was associated with a higher odds of dermatomyositis and with lung disease. And then the heavy metal exposure was associated with an increased risk of lung disease. And this is interesting. One of the there are other sorts of clues that have come up in the literature. There's this observation that patients who have been exposed to ground zero, for example, which would have a large amount of silica dust exposure, that they had a higher incidence of autoimmune disease kind of broadly, but among them is myositis. And so this is just another source of evidence in support of that. So it's not like the only thing, it increases the risk. The risk in the general population is small, but it's measurable and it's consistently present. All right. And then this was another case. This is looking at dietary triggers of myositis. So there are a few things that have been shown in isolated case reports to be potentially linked to the onset of dermatomyositis or the onset of flares of dermatomyositis. And there are several supplements and things or diet supplements that have been shown to potentially cause flares or contribute to flares in certain patients. And so this was a case that built on prior reports. So this is looking at spirulina, which is a cyanobacteria, also called a blue-green algae superfood. It is a common supplement with many antioxidants and other potentially beneficial compounds, but is also has the potential to trigger inflammatory responses in certain individuals. And so there were a couple of cases from Penn that identified either new onset disease or flares of disease in people with other autoimmune diseases, including pemphigus vulgaris, but also dermatomyositis. And so this case was a 60-year-old woman with who had begun this new spirulina supplement, and then within a week developed dermatomyositis that was fairly classic. So with the V sign and Shaw sign and the nail fold capillary changes, skin biopsy fit, all of those things fit. And then they wound up having anti-MI2 antibodies, further supporting the diagnosis. And so interestingly, some of the one of the kind of intuitive assumptions you make is that if you had something that was set off by an environmental trigger, all you need to do is subtract that environmental trigger and it would go away. And perhaps that's true eventually, but in many cases the disease can be self-sustaining once it's set off, and it needs to be interrupted in order to gain control again. So this patient had to be treated with steroids and IVIG before the condition came under control once again. But it's an interesting instance of another kind of potential environmental trigger for dermatomyositis. And yeah. All right. So I want to just speak very briefly about autoantibody tests in myositis. This is something I talk about every year, and specifically focusing on the relationship of myositis to cancers, because it's a question that people have frequently, and I just want to explain kind of or at least my interpretation of the current literature on this topic. So let me take a step back. So one of the biggest insights in myositis over the past 30 to 40 years has been the identification of specific autoantibodies. So an autoantibody, antibodies are made by B cells, they're white blood cells, in response to vaccines or things in the environment, and they protect us from those things. They're involved in the immune memory. And they have a specific target that's the same. So if you want to look for an exposure to something in the past, you can see if you have an antibody to that, and that means that you've been exposed to that thing. And if you have So an autoantibody is an antibody that targets some protein or some part of your own body. So normally you shouldn't make immune responses against yourself, but in this case you make it, in autoimmune diseases you do. And there are characteristic immune responses that target one protein or one part of DNA or one RNA protein conglomerate, and that those are associated with specific autoimmune disease entities. And they're a way that helps us define different autoimmune diseases and then predict what types of manifestations are likely to be present. And in myositis, there's this huge number of antibodies that have been identified that that have different features. And so one of the ways, that this was shown to be valuable was looking at cancer risk. So there are two antibodies that are associated with cancer risk. There's this one, the TIF1 gamma. It's also called the P150/140, and the NXP2 or MJ antibodies. And so the way that you could think about it, so if you look at patients with dermatomyositis, maybe 20% of them, when the disease begins, it begins around the time of the onset of a cancer. That a cancer is identified relatively soon around the time of diagnosis. And if you just look at those patients and you look at the antibodies that they have, the bulk of them are going to be either TIF1 gamma or NXP2. If you look at the other way, if you look at all myositis patients, with those antibodies, only a fraction of them are going to have cancers. So it's not like the antibody equals cancer. It's that these antibodies are, are seen more often in people with cancers. So, and that there are certain antibodies that are associated with a much lower risk of cancers. So the anti-synthetase antibodies, HMGCR, MGA5, it's not zero, but it's much less than with these other autoantibodies. There's also a further impact of age. So TIF1 gamma is very common in children with juvenile dermatomyositis, but that is not associated with cancer in that patient population. And what we think is going on is that there is an immune response. You can see mutations of those proteins in the tumors from patients with the cancer-associated dermatomyositis. So I think that there's an immune response against those tumors, and because those tumors share proteins with other healthy tissues, that the immune response fighting the cancer can result in collateral injury to these other tissues, and that results in the disease. All right, so but because we have this window of the antibodies, we're able to decide how to evaluate for cancer, and we can stratify people into different risk groups depending on the autoantibody status. And so the higher risk group would include people with the classic form of dermatomyositis and also these autoantibodies. And then they get, extra scans at the time of diagnosis. And importantly, I just want to emphasize that the risk of cancer is not like a permanent thing. It's that at the time of dermatomyositis starting, there's an increased risk of cancer being present at that moment. And then as time passes, the likelihood that there is a cancer that's driving everything that hasn't become obvious, after a couple of years, 2-3 years, becomes increasingly unlikely. And then the risk returns back to the general population risk. So it's important to do those tests early, and then later on, you just do age-appropriate screening. All right. So the next thing that I also touch on every time, is exercise in myositis. So this is extremely important in all forms of myositis. It can be a little counterintuitive. We know that when you exercise, you are creating, tiny injuries, micro injuries to muscles, and then the muscle repairs itself. And it's in that process of repair that it gets stronger and the muscle fibers get bigger. And And so it seems like if your muscle is injured already, shouldn't you avoid injuring it further? But it turns out that that process of ongoing repair is just normal for muscle function, that it's important for muscle health, and that it is beneficial to continue to do exercise. So when it has been studied, there's been no sign of increased risk of flares or worsening disease with exercise. That physical therapy is safe at almost any stage of disease activity. And then, just within reason, so like any exercise regimen, you want to start, light and then build incrementally from there. So, so you don't want to overdo it. You want to start at a low level and then build, but that should be broadly beneficial. And just like it is for people without myositis, it's broadly beneficial in that setting. But furthermore, for myositis, there is evidence of a molecular level benefit with improved endurance and even disease activity that can get better with exercise. And there's specific types of exercise that are being evaluated in ongoing studies. So one that had particular detail with it that came out recently with long-term follow-up was one looking at high intensity resistance training in myositis. So that refers to basically weightlifting, and it's weightlifting that's not many repetitions of a low weight. It's trying to do fewer repetitions of a higher amount of weight. And that has been shown to be beneficial in a lot of populations, just to help prevent muscle loss and maintain strength. But it had not been shown to be specifically beneficial in myositis. So that's what these investigators sought to do. And so they had 32 patients with PM, DM, or necrotizing myopathy, 15 of whom got the exercise, 17 got usual care. And they did these exercise sessions twice a week for 16 weeks. They had a warm up, they did these, specific exercises, and then they did sort of a build up. So for the first month, they did lower amounts of weight. And then once they got a sense of where they were, they increased the weight so that they would only be able to do 10 repetitions per set. And that set of exercises showed considerable benefit, I'd say. So there were a number of tests that they've done to look at just general muscle function. So they showed better muscle endurance. They showed better function in terms of a timed up and go test, the time to rise from a chair and walk 3 meters and then turn around and come back and sit down, or the distance that's traveled in 2 minutes. All of those things got measurably better in the people who were treated with the resistance exercise. The muscle testing, the stuff that I would do in the office, that improved measurably. And that, the strength improved for the individual exercises. So the patients who were weightlifting saw an improvement in strength, like you would expect. And then particularly encouraging from my point of view was that the muscle endurance difference persisted. It was still evident, even when that formal program was done 1 year later. They still saw better muscle endurance on a test called the FI3 at 1 year. So it shows real promise for this type of rehabilitation to improve function. Yeah. All right. And so then this is just showing, this is a different way of measuring function. So this is the something called the SF36, looking at physical function. It's a questionnaire that asks about different aspects of physical function. And so the people who got the intervention, they started here and they tended to improve on the whole by the second assessment. And then this was the usual care group that did not show a big difference. And this was significantly different. All right. So I'll turn to some updates and treatment of PM and DM. So this study had come out a few years ago, and I just want to touch upon it because I think it's really important. And there's some nuances that have come out looking at the data kind of in different slices and in different ways. And but you know, basically this was a phase 3 study of IVIG for dermatomyositis. They enrolled 95 patients with active dermatomyositis, and they needed to have active muscle involvement. And patients either got IVIG or placebo for 4 months, and then everyone got IVIG for 6 months after that. And the primary outcome was this measure called the total improvement score that looks comprehensively at myositis activity function. And they saw that there was a very big difference, that the IVIG helped you know, a much larger proportion of patients meet that outcome goal versus the folks on placebo. And so there was a clear impact specifically on muscle. That was, you know, one of the biggest things that was examined. And if they looked at other aspects of disease activity, so all of these other measures, so pulmonary disease activity, arthritis, GI disease activity, in particular swallowing, and constitutional activity, so even just fatigue, all of those things gotten better measurably. And this is just a point that I emphasize to patients and to other doctors, actually, is that, you know, particularly for dermatomyositis, the creatine kinase levels, they can be a helpful indication of disease activity, but they don't necessarily capture every part of disease activity. So these are the folks who are enrolled in the trial who got IVIG or placebo, and their creatine kinase levels were normal, or, you know, close to. But nonetheless, the folks who got treated had capacity to get significantly better function-wise. So the fact that the creatine kinase level was normal shouldn't be reassuring necessarily if the function is poor, that they still need to look. And as you can see here, this MMT8 score still shows pretty substantial ongoing weakness. And this is the physician global, patient global. Those are both, you know, on a scale of 1 to 10. So it's, you know, moderate disease activity. And both the physicians and patients agree. All right. And then importantly, IVIG does have the potential for side effects. And the most common ones were headaches, fever, and nausea. And I think the one that's most common, that comes up most often for patients, is the headaches in particular. And then the study also pointed out there were a number of clotting events that occurred. There were 6 that occurred in 5 patients. They did not see any deaths. And they did look at subsequent studies and showed that the patients with the clots had other risk factors for the clots. But I think a separate study that was important had shown that there's an impact of the way of dosing. So when you give IVIG, you're giving a lot of protein, you're giving a lot of antibodies into the bloodstream, you know, at the same time. And so the risk of side effects is related to the size of the dose and the speed that you give it. So the highest risk is with the biggest dose back to back once a month. And then if you spread that dose out, that risk comes way down. And that is true for headaches. That is true for the clots. That is true for, for the other side effects as well. But that, you know, obviously is a cause for concern. And so this question of the clotting risk was examined a little bit more closely. So this was looking at clotting risk in DM patients in the MGH system. And they saw that there were lots of blood clots that were identified, but it was not particularly associated with IVIG. That clots were sort of a risk of DM for a lot of reasons. This is a condition that's associated with inflammation of blood vessels and diminished mobility. And both of those things contribute to blood clot risk. And a number of these occurred in patients with cancer, which is another risk factor for clotting. And so there may be other factors that are playing a role. All right. Another thing that I'll touch on, that I've touched on in years past, has to do with JAK inhibitors, this class of medications that has shown promise in dermatomyositis. And so this was a preliminary study looking at tofacitinib, one of these JAK inhibitors that's used to treat rheumatoid arthritis and psoriasis and a variety of other conditions. And so this was used in 10 patients with dermatomyositis, and they had shown a pretty dramatic improvement with regard to strength, and in particular with regard to skin symptoms. So people did much better. And that benefit was sustained with long-term follow-up. And so 7 of the 10 continued after 20 weeks of treatment, and they continued to do well. So this was a patient who had rash at baseline, and then it got significantly better, and then was almost completely clear some months later. There was this interesting hint of possible improvement in calcinosis. So that is, is a very preliminary finding, but this is a kind of thing that some patients develop calcium deposits in the skin, and that can be quite bothersome. So it's something that doesn't respond particularly well to other therapies. So it would be, it's an intriguing thing that we hope is also evident on other trials. And there have been other follow-up studies that have shown promise as well. So similar kind of like, not clinical trials, but case series where other JAK inhibitors, related molecules were used as well. So there's one called ruxolitinib and baricitinib and upadacitinib. And so all of those have shown some benefit in different populations of patients. And interestingly, there may be important differences between these agents because the JAK proteins, there's a set of 4 of them that affect different aspects of the immune system. And so each one of these drugs affects, they're not perfectly selective, but they affect one more than the other. So it's possible that different drugs will have different impacts, and one might be better or worse for myositis, and we have to see. But that is something that is, is an exciting area where there's a lot of potential change coming. The other thing that is of interest is that tofacitinib specifically is reaching the end of its patent exclusivity. So that will have an impact on the treatments that are used probably globally in the coming years. All right. This was interesting. So ruxolitinib is also available as a cream. So that is FDA approved for the treatment of eczema or atopic dermatitis. And so this was a case of 2 dermatomyositis patients with resistant skin manifestations, one with JDM, one with adult DM. They both had been treated with multiple agents, but had ongoing skin disease. And they saw significant improvement with relatively prolonged use of ruxolitinib. And this has prompted a small trial that's ongoing at the Cleveland Clinic to examine this for resistant skin disease. So hopefully we'll have some outcome of that in the next year or so. And there's as I said, this is kind of an exciting time. There's lots of ongoing trials. And I think the IVIG trial spurred many other trials. And so once it seemed feasible to do trials successfully, then there were lots of drugs that could be tried and are being tried. So I mentioned this is brepocitinib. This is a different JAK inhibitor. And so this is nearing study completion. We should be hearing, about the results, say in August or September. So hopefully that is positive. There's this molecule I'll talk about in a little bit more detail called efgartigimod or Vyvgart. Dazukibart blocks an inflammatory protein called interferon beta. Anifrolumab is approved for treating lupus, but is in trials for dermatomyositis. And that also blocks this interferon inflammatory protein. And then there's other trials as well, and I'll talk about those too. All right. And then this, I didn't have a great place to put it, but I just wanted to touch base on this. This is a question that comes up quite often, is whether statins can be used safely in patients with PM or DM. And, we know statin drugs are important for controlling cholesterol. and reducing the risk of cardiovascular disease. And but among the most common side effects, maybe happening same thing like 5 to 10% of the time, the patients will have muscle pain or an elevation in the creatine kinase level. And then there's this very rare association, but very real, potential to set off this other type of myositis, the HMGCR positive IMNM. And so, but the question is whether outside of those patients specifically who should not get statins, is there an increased risk of statin use in PM and DM patients more generally? And so this was a study that tried to answer or try to address this, at least in part. So they had 80 patients with PM and DM who had known high cholesterol. And then some of the patients had higher risk because they had visible carotid plaques on ultrasounds. And their myositis was well controlled. And so they took those patients, they evaluated those to, either patients who did not tolerate statins in the past or had some other, contraindication like unstable disease that became unstable. Those patients were not started on statins, but the rest of the group was. And they were treated with either rosuvastatin or ezetimibe, which is another non-statin cholesterol medicine. And for these patients, cholesterol got better. And importantly, among the folks whose disease was well controlled when this was started, there were no myositis flares that were recorded. So it may be reasonable for well-controlled myositis patients to try it. That there may not be a great risk from that. And there's certainly patients who can tolerate it just fine. And that there are patients, just like patients who don't have myositis, who don't tolerate these agents. And then there's other solutions, thankfully. All right. And so I think maybe just in the interest of time, I'll skip over this. So I just want to just make one point about the treatment in myositis. And I think that for PM and DM in particular, my practice has been, and I think learning from the wider myositis community, is that you can treat more aggressively with combination therapy early, that you want to see improvement, and that your goal, your expectations matter, that normal or near normal function is possible, and that you should be making progress towards that on the therapies that you're on. And if you aren't making progress, then something about your regimen should change, and that you shouldn't be satisfied with, less than that when you could do better. And this was actually an interesting thing. This kind of approach. It had been kind of informally present in the community, but it was sort of formalized in these recent JDM treatment guidelines, where it's not like a clinical trial defined that this should be a goal, but this is just sort of like an approach to controlling these diseases, that you should see some degree of improvement within 6 weeks, and you should see more improvement by 3 months, and you see normal muscle strength by 6 months. You should be off steroids by 12 months. And so that's not possible in every case, but that is, if you don't have that goal, if you're not like feeling some urgency to get there, it'll take much longer than that. So I thought that was like an inspiring thing to see. All right. And then, oh gosh, we're running. Okay. So I'd like to talk now about autoantibodies in myositis. And again, I mentioned how important that was before. And, but there's a lot of ways that, that we use the test. And so there's ways of understanding the different kind of subgroups within myositis. And there's increasing appreciation that perhaps the antibodies are directly impacting disease activity. And there's a couple of lines of evidence that support that. So one is that the antibody levels correlate with disease severity, and that's been shown for a whole bunch of different antibodies. So the higher the antibody, the worse the disease tends to be. Then there are these mouse models. So if you take antibodies from people and you put it into mice, you can actually develop muscle injury or other, lung injury or joint injury. And that has been shown either with the transfer antibodies or you make the mouse make its own antibodies by immunizing the mice with the targets of these other antibodies, the Jo1, MDA5. And so that is enough to give the disease. And then more recently, there's this fascinating work that if you look at the actual tissues of patients, you can see evidence of antibodies inside the muscle and skin of these patients. And that potentially also has direct impacts on disease pathogenesis. Importantly, not everybody, the antibodies are not, that's not the whole story. So there are patients whose disease goes into remission, but their antibody is still present at some level. And it's not clear 100% why that is, but that can happen. Nonetheless, this was the antibody internalization. So this was, if you look at muscle fibers of people who have specific antibodies, you can see, and you stain for antibodies, you can see the antibody lining up to where its target is inside the cell. So patients with MI2 antibodies, that MI2 complex is in the nucleus. So if you stain for antibodies, that shows up in the nucleus. And if you have MDA5, that's in the cytoplasm and just like the outside of the nucleus of cells. So you can see that that is where you see the antibodies in MDA5. And this has, this has measurable effects and potentially contributes to disease activity. And so this has been attempted to be targeted kind of indirectly. So rituximab is a medicine that removes the cells that make antibodies, the B cells, or at least a subset of them. And so this was a very large trial that was done. It didn't formally meet the endpoint, but most patients improved by the end of the study. So this is looking at the whole cohort. So there wasn't a difference in the people who got the medicine early versus who got it late. But if you look at more specific subsets, you can see that there are differences. So one is that if you look at the juvenile versus adult, the patients who got treated early improved early. And if you look at patients who had certain autoantibodies like MI2 or Jo1, those people got better faster with the rituximab treatment. So it seems that maybe there's some link to certain antibodies that would indicate that rituximab could be helpful. And so rituximab has been used in lots of patients who have not responded to other medicines, and that has been helpful in many instances. There are some limitations to rituximab as well. It's rarely curative, and that may be due to, it's not getting every single B cell. It's not clearing everything out totally. There are other types of cells that make antibodies too. It often requires long-term therapy, so it's not just like a one and done. And that the antibodies that we think of, that help us with the diagnosis and the subgrouping, those stick around for the most part. And then there are important toxicities, so you could have loss of good antibodies as well as bad antibodies. You can have diminished vaccine responses. It's immunosuppressive. You can have infusion reactions and allergies. And also all those things can be problems with rituximab for all the good that it does. And so there's some other kind of next generation therapies that exist. So that focuses on the cells. Then there's this other, developing technology that, may be useful as well. So this looks at something called the neonatal FC receptor. So this is a protein. This is not working on the cell level. This is working on the antibody level. And so this FcRn, the neonatal FC receptor, this helps to move antibodies across barriers. So it helps to move antibodies across the placenta. That's why it's called the neonatal FC. But it helps to move antibodies from breast milk through the gut and into the bloodstream in newborns. It helps to move antibodies out of the urine and keep them in the bloodstream so that they stick around longer. And it helps to prolong the life of antibodies as they make their transit through the immune system. So drugs that block that function result in antibody levels falling, and they fall by about 50%. And so this is actually surprisingly is well tolerated, and has been shown to have measurable positive impacts on the treatment of multiple diseases. So it's actually drugs that target this are FDA approved for the treatment of, there's a condition called myasthenia gravis that's also associated with weakness, and something else called CIDP, which is a peripheral nerve autoimmune condition. And so you can see here, this on the bottom, this is just this is an improvement in symptoms in myasthenia gravis. And then this is a fall in the antibody levels. You can see that it parallels pretty closely. And there are case series where it's shown benefit in necrotizing myopathy. And so, I've listed a few of those there. The phase 2 results were just discussed at the recent meeting last month in Europe. And so, and the phase 3 trial is now fully enrolled, and we should have results from that, in about a year's time. So hopefully that will be, that will have a positive result as well. All right. And then I have a few minutes to talk about CAR T therapy. So this is another way of trying to address the B cell question. And so CAR T therapy, what this is as a technology that was derived to treat cancers that treat B cell cancers. So leukemias or lymphomas. And basically you take T cells, a different white blood cell from patients, and then engineer them so that they, normally all T cells are unique and they have a unique target. But if you take some cells out, you can actually replace their unique receptor with the same receptor that targets just cancer, or in this case, just a B cell. And you can grow those cells in culture, and then you can give it back to the patient, and that generates an extremely strong anti-tumor immunity. So this technology is approved to treat a variety of leukemias and multiple myeloma. There's different targets you can use. And then there were promising results that were reported in lupus patients, and as well as myositis patients. And there are some limitations. It is very involved to do all these steps. It does require initial inpatient hospitalization up front, and it requires some pre-treatment. So you need to sort of make room in the bone marrow for these cells to grow, to be able to be effective. And that involves sort of a low-level chemotherapy initially. So, and the last is that when the cells work, when they kill lots of cells simultaneously, that, often is associated with this called cytokine release syndrome, where you have sort of fevers, aches, and there's a variety of symptoms that can come with that. And it's essentially like an infusion reaction. And part of the rationale for that is that if you look at rituximab, if you look at blood of patients who are treated with rituximab, their B cells go to zero very quickly. But if you look at tissue of patients who are treated with rituximab, like down here, you can see that there's still lots of B cells present even after rituximab therapy. Whereas after CAR T therapy, you really get rid of all of those cells for a time. And so this was just looking at one example case in myositis. So this is a patient with anti-synthetase syndrome. It was anti-Jo positive, had very severe disease with weakness, interstitial lung disease, high CKs, positive MRI, who had not responded well to lots of therapies, including prednisone, rituximab, IVIG, tacrolimus, and cyclophosphamide, which is sort of like that low-dose chemotherapy. And so this patient was offered CAR T therapy as part of a research protocol and did great. So the patient's strength got almost all the way back to normal. The anti-Jo1 antibodies went away. The lung disease got better. You can see all this white stuff in the lungs got significantly better 3 months later. All the white in the muscle got considerably better. And then did require some treatment for side effects transiently. So so that was exciting, and the experience from lupus was exciting. And there have been a subsequent group of cases that have been reported, looking at different types of patients. So there were a couple more patients with antisynthetase syndrome who've been reported who did really well. There's a patient with juvenile dermatomyositis who was treated, also did very well. A couple patients with necrotizing myopathy who did really well. And importantly, at the end, I just want to draw your attention to this column all the way on the right, that a lot of these folks, wind up off medicines, at least in the initial reports, which is really, which is really exciting. That's a big positive for people. It's very early stages. These are very few cases, but that's part of the reason for the excitement. And there have been some few instances of longer term follow-up. So this was one group that was published in the New England Journal. They had 3 patients with myositis, and their enzymes continued to be good. Their strength continued to be improved. The antibodies either declined substantially or became all the way negative. And then importantly, the B cells, and maybe surprisingly, the B cells came back, that the CAR T cells did not appear to eliminate that permanently. One indication that this may be an early story and not the whole story. There was one patient who failed the CAR T therapy subsequently, and that then was re-challenged with a slightly different CAR, and then that was successful. And so that, I think as more experience is generated, it may not be like a panacea for everybody. There may be some other, downsides, but or patients may need retreatment and may not be a cure in the way that we think about it. So I think there's a lot of things about this that are encouraging. You can see long-term remissions off of medicines, which is a rarity otherwise. The B cells come back, which is also exciting. Autoantibodies that we think are important in contributing to the disease decline, and in some cases go away. But again, I don't want to, I want to share a sense of why everyone is talking about this and why there's so much hubbub, but I do want to emphasize that the experience is limited, that all of the applications of this are in research protocols appropriately right now. And and so it's been difficult here at HSS because we're kind of siloed musculoskeletal site, but we are working with partners at Memorial Sloan Kettering to hopefully begin participating in these protocols in the next couple of months. And so we hope to build that expertise here at home as well. Let me touch briefly about IBM. And so I just want to speak about the sirolimus trial in inclusion body myositis. And so there was a phase 2 study that was published a number of years ago now, that had shown some potential promise in treatment of IBM. And so there's some pluses and some minuses. So on the one hand, the study did not meet its formal endpoint, so it wasn't like there was a complete reversal of the weakness that had developed in patients. But there was less of a decline, so that things were changing less in the sirolimus treated group versus the placebo group. However, there were some positive changes that were noted. So this is looking at the 6-minute walk test. So this is the distance that was traveled in 6 minutes. And so the folks who were treated had stability by that measure. They had stable measures of breathing, and they had less scarring that was evident on MRI. So all those things seem positive. And potentially with a longer study with more patients, it may be possible to see other positive features as well. And so on that basis, there's a phase 3 study that's ongoing. There's 140 patients who are enrolled. to complete 88 weeks of treatment. And the estimated conclusion of that study is December 26th. So, about 18 months from now. And then this is another important ongoing trial in inclusion body myositis. This drug ABC008 or alviprubart is the other name for that. And this is a phase 2-3 combined randomized placebo-controlled clinical trial. And so there are 231 patients enrolled, some of whom have completed the trial and entered the open label phase, which means that they're everybody who completes the trial is able to continue to receive the medicine, and then the treatment period is going to last 18 months. So the final patients enrolled will complete that phase of the study in, say, around December 2025. So the answer for this, or the result of this trial, is likely to be reported around, say, January, February 2026. So it's been a long time coming, but hopefully there'll be some good results there. And so the way that this medicine works, it is a biologic, and so it's an antibody that targets a protein called KLRG1 that's on the surface of certain white blood cells, and that those cells with that marker are expanded in the blood and muscle of patients with IBM. And treatment with the medication removes those cells with that marker, and then the cells eventually come back, but it takes a couple of months. And so the medicine is given every couple of months in order to maintain control of those cells. And so the hope is that if we think that those cells, there's a lot of circumstantial evidence to pin them at the scene of the crime, that if removing those cells makes a meaningful difference in disease activity, we should be able to see it by making that intervention. And one thing that I would say about the conduct of the study is that there's a whole lot of other information that's being gathered about lots of details about individual patients that will help to discern, if there are patients, if there's a subset of patients who benefit more, benefit less, they'll be able to discern that as well. And so that's a reason for excitement and for hope. And yeah, so hopefully we'll see something good in a few months' time. All right, I know I'm running over slightly, so I'll just touch very briefly. We have a myositis registry for patients, and our goal is to gather comprehensive information about myositis patients and measure disease activity in history in a structured way. And then we collect blood samples. So it's really a minimal commitment, only at times when people are here for clinical visits anyway. Yeah, and so that's allows us to do some of the translational work that we're doing, which is focusing on those same cells that are targeted, at least in part, by the ABC008. So the white blood cells in the muscle of IBM patients are predominantly this type of T cell. It's called a CD8 positive T cell. And these cells show sign of hyperactivation. So they're larger, and they have a specific appearance. And furthermore, it was shown that these cells are not just expanded, but that one identical cell made up like large proportions of all of the cells in the bloodstream. And so that, in many cases, that met the criteria for certain slow growing types of leukemias. And so what we have aimed to do, and we're continuing to do, is looking at, so we could see that the patients with IBM are more likely to have expanded CD8 positive T cell populations, just like the other groups have seen, and that it has this highly activated appearance. And then what we are focusing on is looking at mutations that are present in those expanded cells. We're doing sequencing to evaluate that. And I hope to, be able to share that with you as soon as we have that ready for publication. So in conclusion, I think that there's a lot of room for there's a lot of reason for excitement. There are lots of potential developments on the horizon. The pace of clinical trials is really accelerating, and the kind of the mechanics of doing trials successfully and doing more trials. It seems to be a tide that's at the flood rather than at the ebb, and hopefully we can really push that while we have the wherewithal, and we have the support of partners in industry and government. And hopefully this will bring us closer to understanding the causes of myositis and allow us to design and test out better treatments, and then try to come closer to a cure for different forms of the disease. So I'd like to acknowledge my colleagues in the lab, as well as my colleagues in the Scleroderma Vasculitis and Myositis Center. Definitely big thank you to Susan for all the work she does with the support group and for myositis patients. And yeah, so with that, I'll take any questions.